All right, perfect. Well, thank you so much for having me today. I'm Dr. Rughwani, and I am one of the attending geriatric outpatient attendings at both Mount Sinai on the east side and also at Mount Sinai Morningside, where we have, if you don't know, a new geriatric outpatient clinic, although it's not so new. We've been there since August of 2019. So we've been there a little while, so thank you. So today I want to talk to you a little bit about kind of falls and how important falls are in our older adults, how you can recognize them. I'm sure all of you have seen patients who've been admitted for falls, and kind of giving you a little bit of information about it. So a little bit of background. Every year, about 3 million older adults are actually treated in the emergency room for fall injuries. And this actually leads to increased morbidity within our older adults and also functional decline. And actually, there's an increasing amount of evidence that's showing now that if you can have interventions that help, that they can actually significantly reduce falls and, more importantly, the fall-related injuries that happen in older adults. So the big problem is you need a standardized evidence-based approach for falls assessment in older adults. So, oh, you know what? I am going to do slideshow. Sorry, I forgot about that. All right. Can everyone see this pretty clearly?
Yes, we can see it, but we see it in the presenter view with the notes. If you can just swap the displays up top. There's a button there. So you see there's, yes, swap displays, like to the left. Perfect.
Okay, perfect. All right. So if you can take a look at this, you can see this is a graph describing kind of fall death rate within the United States. And from 2007 to 2016, there's been a significant increase, okay? It's about 30%. And if this rate continues to rise the way it is rising right now in this graph, we will end up by the year 2030 having 7 fall deaths every hour. So that's pretty significant if you think about, you know, not just how many people falling, but the number of people that are actually dying from their falls. Oh, gosh, sorry. Can you see me? Oh, Lord.
No, I think that the screen might have frozen, like we see a part of it and only pretty small. Yeah, I think it's best if you stop sharing and reshare. Sorry about that.
Okay, that better?
We see it now. Thanks.
Okay, great. Okay, so death rates of falls within the United States, and this is falls per 100,000 by age, sex, and race. And you can see as people get older, they tend to fall more. The rate actually increases significantly, and the highest rate is actually in this 85 and above group. And white males seem to be predominantly the ones who actually fall the most. Followed by white females, and then black men, then black females. So what is a fall? And the definition is it's an involuntary event that results in a person coming to rest on a lower level from a higher level with or without the loss of consciousness. So this is the actual definition of what is a fall. And as I talked about it earlier before, what is the significance of falls? So falls are actually a very important marker for frailty, immobility, and kind of the acute and chronic health impairment in older adults. And as a result of falls, it actually diminishes function by causing injury, activity limitations. So people who have very active lives, once they've fallen and recovered from it, sometimes they can't go back to their usual active self. Then they have this incredible fear of falling, where they're just afraid that they're going to fall. And so their gait and balance as a result changes, and they lose their mobility because they're just not as confident. And the biggest issues that happen in older adults with falls is that they can have fractures. So they can fracture hip, which is the most common, pelvis, forearm, humerus, and those are actually the biggest kind of injuries and fractures that we see from falls. The other thing to remember is that in our older adults, they also have a significant amount of osteoporosis, which then in turn puts them at a higher risk of fracture when they do fall. So what are the causes of falls? So medications can actually really affect falls. And, we'll talk a little bit about that in a while. Gait and balance, neurological, cardiovascular, vision, hearing, joints, mobility, and environment. So we like to break them up into intrinsic and extrinsic risk factors. So if we look at the intrinsic risk factors, as I mentioned at the graph, age over 80 for men, right? So, and women are also at a higher risk. And then people who have generalized decreased ADL and IADL scores. So this, in case you don't know, is the activities of daily living and the independent activities of daily living. The way I like to remember ADLs is you get up in the morning, what do you need to do to get out the house? So you need to mobilize to the bathroom, you need to groom, you need to bathe, you need to ambulate, you need to toilet. All of those things are important in ADLs. And IADLs are things that help you do those things. So for example, using the telephone, being able to shop, being able to take your medications, your finances, and so on. People who have a mobility impairment already will be at an increased risk. And also people who don't exercise much or have very decreased activity. Any past history of falls puts someone at a higher risk of falling again. So some of the medical conditions that are important to think about as your risk factors are arthritis, Parkinson's. So arthritis, obviously, when people have pain, their gait is a little altered. Similar with Parkinson's, the very typical freezing, the kind of slow stooped gait, shuffling, they're all high risk factors for fall. Dementia is also important because as people may not remember things as well, they're not necessarily coordinating everything that they need to do from getting from A to B in an effective manner. People who've had strokes and any kind of hemiplegias, postural hypotension, which is obvious why. Urinary incontinence is another one because people suddenly need to get up to go to the bathroom, or they have an accident and that can also alter the way that their gait is, or it's slippery on the floor. Then people who have any reduced knee, hip, or ankle strength. Grip strength is another good way of evaluating people. People who have arthritis, as I talked about, foot problems, slow reaction times. Sensory, very important. People who have cataracts, glaucoma, people who have macular degeneration. Things to think about that are common in the elderly population that would put them at higher risk of falling. And that is because they either have a reduced depth perception, so they can't, and that's a problem with stairs because they don't quite see exactly when the next step is. Some other intrinsic factors is some neurological signs. If you find some cerebella, pyramidal, extrapyramidal, and we talked about gait abnormalities. Another one's actually someone who has a reduced walking speed. That can also be a problem. And their kind of balance and tandem gait not being so good. Depression has also been thought to maybe cause some increased risk of falling. And I talked about medications, and the common meds are sedatives, hypnotics, anxiolytics, antidepressants, some of them, some cardiovascular meds if they cause intense blood pressure differences, NSAIDs, and some others as well. So I've got them here in a list for you. The good way to think about it is any anti-drug, okay? So neuroleptics, as I said, sedatives, hypnotics. So antidepressants, antiarrhythmics, anticonvulsants, antihistamine. And that is a very common one that we don't think about always because of the cholinergic effect. That is a huge risk factor for falls. And the other thing to really think about when you're evaluating these patients are polypharmacy and having multiple medications that may interact with each other that cause patients to fall. So some of the extrinsic risk factors, right? So that is outside of that person. Any kind of equipment, things like beds, the commode, using the bathroom. And it can, typically you see it when they're going from transferring. So if they're going from a chair to the bed, or the bed to standing up, or they're, clutter in the home, things like that can be a problem. Physical restraints. So you know how we try and avoid them in hospitalizations. Part of that is because if they're trying to get out of restraints in hospitals, it's a very common cause of falling, because they're trying to get out, and the few minutes that you're not seeing, they fall. And I talked a little bit about kind of medications, because that's extrinsic, and also the interactions between medications. So this is just kind of a visual. If you have antidepressants, it causes impaired strength and balance. So does neuromuscular change, inactivity, knee arthritis, poor vision. They all cause this impaired balance, impaired strength that causes people to fall. And these are, again, looking at some of the different interactions of risk factors, right? So if there's poor lighting in the house, or there's a home hazard, you put the two together, boom, they've fallen. They have some illness, they have an increased fall risk because of that illness, they'll fall. Or they're hypotensive, and we don't really see that their blood pressure is a little low, and we give them more medication, or we continue their home meds, not thinking that, maybe they need new regimen now, they can fall. And people who are obviously tired, distracted, are also at greater risk of falling. So there's this risk triad, really a multifactorial etiology, right? Intrinsic, which we talked about, extrinsic, and then you have these kind of mediating factors, risk-taking behaviors. And that's usually based on an underlying mobility. So to give you an example, I have a patient who has Parkinson's. His mind works brilliantly. He got this very fancy walker that comes up to his, it's a high walker with 4 wheels. Problem, he can go with the walker, but the minute he freezes because of the Parkinson, and he's had very difficult Parkinson's to treat, the walker goes because it's on 4 wheels and he can't go with it. So he's fallen. And actually this week on Monday, he was in the emergency room because he went through a glass door and got a severe laceration. So, things I've multiple times said to him, that's not the ideal walker for you. He even has an electric scooter at home, but part of it is he's not able to mentally keep up with his physical disease. And so as a result, wants to be more independent than he can. So all of these things together are problematic. So how do you assess these patients, right? So you're in the emergency room, you get a call, someone's fallen, they have a hip fracture, they need you to assess that patient. Oops. So what are some of the important things in the history? You want to know, what was the circumstance around that fall? Where were they? What time of day was it? What were they doing when they fell? How did that fall happen? And I'd like to get a really good history about this, because this then helps you to find out what is the etiology of that fall. Then you think about, you ask that question, what were some of the other symptoms that you felt when you fell, or before you fell? Were you lightheaded? Did you actually syncopize? Were you dizzy? Did you have chest pain? Were you weak? Did you have palpitations? What preceded that fall? Was there any particular symptom that you had? Another good important question is, have you fallen before? Because as I said, previous falls are a risk factor for more falls. And then kind of getting a full medical history to see what are some of the comorbid conditions that might be relevant. And then doing a full medication review. And this really does include herbal and over-the-counter drugs. I cannot stress this enough. It happens all the time where they're taking, I had a patient I saw, nope, not taking any medications. Oh, and by the way, as he's walking out the door, he gives me 2 full pages of A4, literally single spaced, of all his supplements. So more than not, especially older adults, they like to take supplements because it helps them feel better, because they think it's a natural way instead of taking medications, without realizing some of these meds can be very lethal. And then kind of what's their general functionality, right? Are they independent with their walking? Do they use an assisted device of any sort? And if they do, what kind of device is it? And then do they drink? That's another big one. Oh, I don't drink very much. And, we have very presumptuous in our thinking. So you can see a little old lady and you're like, oh, you just presume that she's not drinking, and yet, she has 4 cocktails a night, and funnily she falls every night or has fallen at night, something along those lines. So just really thinking outside the box when we look at our older adults. And then what is their environment like? It's sometimes hard to get this information in a history, but a question that I tend to use is, do you find that you have a lot of obstacles in your way when you need to try to get to the bathroom? Or, do you find you've got rugs that are not kind of well put down and you might trip on them? So trying to get a sense if they live in a cluttered house or have rugs, or, something was in their way when they fell or tripped. Then you examine the patient and what are you kind of looking for? So obviously vital signs, and then really important to do orthostatic blood pressure, because even though someone's vitals may look perfect, they could be orthostatic, which may have contributed to their falls. And then head and neck, you want to kind of ask and check the hearing, vision, see if they have any bruits, watch them walk, look at their mobility, any limitations, any postural instability, any podiatry problems, look at their feet. Do they have large bunions that cause pain so they are falling? Or look at their shoes, they're wearing very slippery shoes or wearing socks in the house and a wooden floor. Then you want to do some neurological testing, reflexes, check their mental status, any neuropathy, muscle weakness, gait disorder. You want to listen to their heart for murmurs, any arrhythmias, and then some of the functional assessments, which are really, really important in our older adults. And, things like gait. When you're watching them walk, watch them walk a significant amount. If they can walk, sometimes they cannot, but if they can, get them to walk, get them to turn, and watch them come back. The turning is really important because it shows you how steady or unsteady they are. And it, along with that, you can have them do some tandem walking, which is really one foot directly in front of the other, which is very hard to do sometimes for our older folks. So always make sure that you are standing behind them in case they fall, you can catch them. Then the 30-second chair rise, which I'll discuss in a minute, the get up and go, which I'll talk about, static stance, and a functional reach, which I'll go into more detail in a minute. So you're watching them walk. What are you looking for? You're looking for kind of what is their stride length? Is it very small, slow and shuffling type, much more kind of in the Parkinson's route? What is their arm swing? Do they have good arm swing? Do they have no arm swing? Are they slow? Are they fast? Are they, sometimes some people are slow to start and then they go running and that's why they fall. Are they flexed forward? Is their head and neck kind of just completely bent over so they're not actually able to look what's coming in front of them? Is there a flexion of their shoulders, of their knees? Do they have more of a lateral sway? And what do their hips and knees? What's the flexion of their hips and knees? So some important things to think about as people age and some age-related gait changes, that things that might be abnormal, right? So if they have a very broad-based gait with small steps, diminished arm swing, they're stooped, they have a decreased flexion of their hips and knees. So when they're walking, they're kind of walking like straight-legged almost, that they're not able to have an appropriate gait because they can't flex their knees and hips. And then this is the one that I talked about when they turn, they're very uncertain when they're turning and they're very stiff. So that definitely puts someone at a higher risk of falling when they're turning. And then an occasional difficulty in actually initiating steps. And some of the conditions to think about that might be causing the gait impairment would be things like dementia, peripheral vascular disease, right? If they're having decreased blood flow, some orthostatic we talked about. Sometimes people have orthopedic surgeries. I have a patient who had broke her hip. Now she's got a leg discrepancy of about a good 2 inches. That may not seem a lot, but it is actually very significant because now her gait's completely off and it puts her at a very high risk of falling. Any degenerative joint disease, so arthritis, especially significant ones of hips and knees, will cause a problem. Fear of falling, as I said, is huge. And then impairments following a stroke. So even though they may have gone through rehab and and all of those things, some people still have some remnants of their stroke, so that makes them not be able to ambulate very well. And any other acquired musculoskeletal deformities to think about. So the 30-second chair stand. This is a very well-established geriatric test, and it really is used to test leg power. And it's very useful for detecting any early age related changes in functional status. So what is the purpose? As I said, is to test leg strength and endurance. And what you need is a chair with a straight back without any armrests, and you need a stopwatch. So this is your instructions for the patient. You say, sit in the middle of the chair, put your hands across the shoulders. So it's kind of this where you're doing this, okay? And you say you have to keep your feet flat on the ground, and you have to keep your back straight, and you got to push your arms against your chest. And when you say go, they have to stand up and sit down and stand up and sit down. And they're supposed to repeat this for 30 seconds. So that's when you turn your stopwatch off. After 30 seconds, you turn it off. And in the meantime, you're counting how much they can do. So that's the purpose of what you're doing there. And you're going to record it. And this here on the right will give you what the average score should be. So for example, you have an 80-year-old man who can only do 5 of those in 30 seconds. They're really supposed to do about 10. He's got some impairment there, right? So they don't have enough leg power. That could be a problem here. And that's what this is, an abnormal test. Then we do the timed get up and go, which is also known as, the short is the tug. And this is a very detailed assessment of gait, of balance, mobility, lower extremity joint function, functional assessment, fear of falling, and the activities associated with falls and use of assisted devices. So mainly assessing mobility. And here, all you need is actually a stopwatch. And you need to have kind of inch tape or a marker so that you know what is 3 meters or 10 feet away. Okay, so you mark it. And what you do is they wear footwear like they ordinarily would, and they can use their walking aid. So if they walk with a walker, they should use the walker. And you have the patient sit back in a standard armchair, and you mark off where is that 10 feet or 3 meters. And you say, when I say go, you stand up, you have to walk at your normal pace to that point. They turn around and they come right back and they sit down. And you're going to record the time. And the metric here is anyone that takes more than 12 seconds to complete this test is at higher risk of falling. Okay. So another very important test that you can do to see if someone's at risk of falling. And then we do a balance assessment. So we do 3 stances, and we do parallel stance, which is kind of your normal stance. Then you do semi-tandem, where they're one not completely in front, but they're one in front of the other. And then you do tandem, where they're completely 1 foot in front of the other foot. And you see if they can maintain their balance for greater than 10 seconds. If they cannot, they have a problem with their balance. Again, important thing here, stand behind them in case they fall. You want to be able to catch them. You don't want them to fall when you're seeing them. So just to show you what that is in pictures, this is a parallel, feet together, semi-tandem, one side by side, but one in front of the other. And then this is a complete tandem. Functional reach is also another very good test to do. And what you're doing here is actually you're securing a yardstick. So you put it at the height of the patient's acromion. And what you do is you put it against that acromion and then along the wall. And you tell and they should wear a comfortable, they have a comfortable stance. They can wear with or without shoes. It doesn't, usually if I'm in clinic, I would say just leave your shoes on. You have to get them to make a fist, and they have to extend their fist out as far as they can along that yardstick. And you're going to measure how far they went. And the magic number here is greater than 6 inches. So if they cannot get to 6 inches, then you have a problem here and you need to kind of evaluate further. So what do we do? Well, how do we intervene? How do we prevent? So your big goal is minimize the risk of falling without compromising mobility and functional independence, right? So that is our big goal. So we actually, in our geriatric clinic, have a standard fall screening question that we ask every patient when they walk through that door. So every time they come for a visit, we call it the 5th or 6th vital sign. So not only do they get their blood pressure and their pulse and their temp and their O2 sats, we do a falls and a depression screening. And it's very simple. It's 2 questions. Have you fallen in the last 12 months? So that's one question. And the second question, have you been afraid that you would have a fall because of any balance or walking problems? Okay, so 2 simple questions. If they say no and no, you're good. If they say yes to either, then you should do a full falls assessment. This is a busy slide, but it kind of helps to, and I'll go through each one in a bit more detail. But I'll run through it just so we can understand. So this is basically prevention of falls of older adults who are living in the community. So you see an encounter with a healthcare provider, you screen them for falls. If they have no falls, great, you reassess them periodically. Say they have yes, okay, to a screening question. Then you do, as I said, the full history that we talked about before. You evaluate gait, balance, and you try and figure out what is it here that has caused this person to fall, and what are some of the interventions that you're going to do to help prevent that from happening again. So the American Geriatric Society, along with the British Geriatric Society, made some practice guidelines almost 10, 11 years ago now. So you have these periodic case finding, no falls, reassess periodically. If they're having multiple falls, you evaluate for falls. If they have gait disturbance, you evaluate for falls. You're checking for gait and balance, again, evaluating for falls. So again, evaluate, evaluate, evaluate is the basic message that everyone's giving us. Okay, so when I was talking about the history, one of the things I said is spend a long time finding out what was the circumstances of that fall, because you need to try and figure out, well, why did that person fall? If you don't diagnose the cause, you cannot treat it. So it's very important to figure that part out. Look at the medications. I cannot stress this enough. And sometimes they'll bring in stuff and they're using more things at home. Common ones, oh yeah, I just take my Xanax occasionally. I don't take it all the time. I only take it at night when I need to. I didn't bring it with me, or they just forget to tell you. So what I do is I say, tell me all the medicines, also your herbals, also your OTCs. But then I go and specifically ask, do you take anything to help you sleep or to calm you down? Anything along those lines. Reviewing environmental hazards. And then you want to try and optimize vision and hearing. If they can't hear or they can't see properly, that needs to be addressed, right? So maybe they need to see the ophthalmologist, or they need to get hearing aids because that's a problem. And if they need an assisted device, they should get one. And the best way for figuring out which assisted device is usually to have physical therapy, evaluate them and see, well, what can they do? What can they not do? And how can we help them best? And then PT and OT are really important. So a lot of our a lot of our patients who've fallen, they will go see OT. And what OT does, and a very common problem in older adults, is they lose core strength and they lose a lot of their muscles that they need to keep them balanced. Their glutes, their quads, their stomach core and their back core. That all kind of weakens with time. So getting physical therapy to work with them to not only assess what the problem is, what assisted device they may use, but actually also help strengthen some of those muscles is very important. The other thing you can do, actually, the Visiting Nurse Service of New York actually will go into patients' homes and evaluate their home. Take a look at what's going on. Look at all the medication bottles that are there. have them assess the home and say, okay, why do you have rugs everywhere? Why do you have boxes here, there, and everywhere? Why do you not have a grab bar in the bathroom? So they will come back to you and say, I saw this patient at home. This is what they need. Can you please order X, Y, and Z? So that's a really good help when you can't get into the home. Oops. So Tai Chi has actually been proven and shown to be the one exercise that has been beneficial in preventing fall injury in older adults. Okay, so they've done multiple studies, and one of the studies actually showed that patients can sometimes still fall, but they're able to brace themselves and they don't get hurt as much. So that's the other thing to remember. And actually, we're very excited because our nurse is a certified Tai Chi teacher and has just started in the Morningside neighborhood a once a week Tai Chi class for older adults. So we're very excited for that. And already we had 24 people, and people love her class, and it's very, very helpful. And she's really designed the program for older adults. So it's not just for anyone. So the moves are not that difficult. Hip protectors. I have several patients who are obsessed with these. And basically it's almost like sponging around the hips. There's been not enough evidence to say that it works one way or the other. I personally don't love them because I think it throws people's balance off because it's heavier to walk with them. I don't find them very helpful personally. So just to keep that in mind, that you may hear people talking about it. I literally have a patient who comes in, she puts it under her pants every day, even in the hot summer, and she swears by it. But again, the idea there is not that they're going to not fall, but if they fall, that it may protect their hips. But I'm not so sure that that is actually what happens. And then exercise, so a progressive resistive training program. And a lot of the physical therapists are very good about organizing those for patients and giving them a good program. But using resistance to help build muscle is basically the idea here. And safety alerts. So this is really important. And I recommend it for not only people who live by themselves, but also people who live with their families, because if they fall and they're on the floor, it's like there's life alert buttons that you can have where if you fall, you just press the button. They come as necklaces, they come as watches, and they're extremely, extremely helpful. So if you have any older adults, please, please, please have them wear it. Okay. Now, I'm going to go through a couple of studies of what was shown to be helpful with some data around it. So any effective single intervention strategies, they looked at kind of multiple component exercise groups, and they targeted 2 areas: balance, strength, flexibility, or endurance. And these kind of programs have shown to reduce rate of falls and the risk of falling. Overall, exercise interventions, which is what we send patients for, also reduce the risk of fall-related fractures. So it's this part that we're concerned about is the fall-related injury, more so than the actual fall itself. And you really need further investigation to kind of figure the particular parts of that out. But they show that actually exercise programs seem to be much more effective when they're actually embedded within a multifactorial fall prevention strategy. And what that means is that exercise is one component. If they need an assisted device, that's another. If you need to manage their medications, that's another. So it's much more of a multitude of interventions that are helpful to help prevent falls. So you might hear about vitamin D. Vitamin D initially, a while ago, a few years ago, was shown to really help with preventing falls and falls-related injuries in older adults. However, recent data has shown that that may not be completely true, that vitamin D may not reduce falls. They're great for building bone for older adults, but very frequently you'll see in older adults, they have low levels. So checking a 25 hydroxy vitamin D level is a good idea in older adults. You really want that to be greater than 30 to help improve that. And home safety is much more effective in people who have a high risk of falling, especially low vision. So, when they have poor lighting at home, in addition to their ARMD or their glaucoma. And then they have this anti-slip shoe device, especially in icy conditions, that have helped reduce falls. So usually I tell my patients when it's icy, don't go out. However, if they do go out, you see something like this, and you'll see people buy it for hiking, and they can actually attach it to their shoe. And if they absolutely have to go out, they can put it on their shoe, and that helps in snow and in ice. But the number one recommendation is do not go out when it's icy and slippery outside. Okay, so vitamin D, I'll talk a little bit more. In a subgroup analysis, it did reduce falls and reduce risk of falls of about 43% and 30% the risk of falling. There is needed more data. This data wasn't sufficient. And there was also found that there was an increased incidence of hypercalcemia when people took too much vitamin D. So making sure that number is less than 30 is more than 30 is really important. And then if you gradually withdraw psychotropic drugs, you actually can reduce the rate of falling. Also, if you prescribe the way you prescribe your medications and you modify that, also reduce the risk of falling. So really important, right? So drugs, as I talked about, are very important risk of falling. So if you're able to withdraw these carefully and slowly and deprescribe, it's very helpful in your older adults. Education, 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 right? So our patients need it repeatedly because they're older. Data will tell you over and over again what you say to a patient in your office or when you're talking to them, they're only absorbing 10% if you're lucky. So writing things out for them is very important. Giving them brochures that they can go home and read when they're not as stressed in the environment that they're in the hospital or in an outpatient clinic is very important. And the one thing I'll say about medication is that if you tell the patient why you're stopping or changing their medications, they're much more likely to listen to you and not take those medications than if you don't do that. That education piece around meds is very, very important. They need to understand why. Why is it that I don't think that their diazepam is a good choice for them, right? Why do I think that that may be causing them to fall? So there was a meta-analysis of the impact of 9 different medication classes on falls. 22 articles actually met this criteria, and it was a huge study. It had nearly 80,000 participants. So some of the common high-risk medications were diuretics, sedatives, hypnotics, neuroleptics, antipsychotics, antidepressants, and benzodiazepines. So common medications to think about as we prescribe for our patients. And then, don't forget about the cholinesterase inhibitors. These have a high risk of syncope in older adults, much more than placebo, and they had a higher also. So be very, very careful when you're prescribing this. And just remember about the cardio inhibition and bradyarrhythmias that you can get with them, which can cause this kind of syncope. Some other fall risk increasing drugs were known as FRIDs. So as I talked about, some of the antis, they're out there for you. Opiates, obviously, is another one. First generation antihistamines. Really don't like any of this Benadryl, Phenergan, Tavis, like any of those, really not a good idea. You can give our older adults non-drowsy antihistamines like Claritin, Allegra, those are fine. Muscle relaxants, a huge cause of falls. So Flexeril we give very commonly these days, so please try and be careful about that. The other ones are also gabapentin, Dilantin. We use gabapentin a lot for nerve pain and Lyrica and so on. They are all fall causing. And then I talked about the alcohol. So remember to ask the question. If you don't ask the question, I promise you they will not voluntarily tell you the majority of the time. So The other big thing you'll find is this kind of bradycardia that happens in people. That's when we first find out they need a pacemaker. And actually a study showed that pacemakers reduce the risk of falls, and also people who had cataract surgery. So cataract surgery really does cause that blurring of people's vision more so, and it's worse at the nighttime because of the glare. So people who have cataract surgery actually have a lower risk of falling. So what was most effective, as I mentioned before, is a multifactorial falls risk assessment and a management, so that you can really assess all the risk factors and then modify them. And using exercise and therapy and reviewing their drugs were really, when you looked at all the different programs that are out there, those are really critical. It made the hugest difference. And when we looked, there was a study, a Cochrane study that was looked at, where assessment and actually multifactorial interventions reduce falls, not only the risk of falls, so just the actual falls. So this study was a systematic review from the USPSTF. So it was a huge study as well, looked at a lot of, it looked at a lot of data, and it looked for exercise and physical activity and vitamin D. And it showed that each one of them actually reduced falls in community dwelling older adults. This was, they had a control group, everyone was over the age of 65. It was set in a primary care setting. And the outcomes that they looked at was the number of patients who, or participants who fell. And this was actually a good or fair quality study that came out from the USPSTF. And then here you can look at kind of some of the data around that, between exercise, vitamin D, home hazard modification, and this multifactorial assessment and management. So I want to also talk in the last few minutes, I wanted to leave some time for questions so that I know we have limited time, but we have a falls evaluation clinic over at Morningside. Right now it's run on the first and the third Friday of every month. Sorry, it's actually Wednesday now, not Friday. And we are happy to see patients who have fallen. Our team is, it's an interdisciplinary team of an attending, medical assistants, we have a nurse, we have the social worker. Inclusion criteria is anyone age 65 and older who've reported 2 or more falls in the last 12 months, or they've had a single fall that had injury that required treatment. They can be living independently or in an assisted living facility. We don't really see nursing home patients or people who are acutely, like if they've just had a stroke or a hip fracture and they're still in rehab, we're not going to see them until they're done with that. And anyone who has severe dementia, we're not going to be able to see, because I feel like the interventions there, except for medication modification, is a little bit more limited. So the visit is really, patients are thoroughly evaluated only for falls. And the key thing here is that we follow up very closely with them between phone calls and visits to make sure that all recommendations that are made are actually followed through. Once they're stable, we send them back to their primary care providers. So the best way to do this is a couple of ways. You could either send a staff message, and you can use this recipient, MSM Jerry Falls, and you can call this number, and I'll give you the slides so you have them. Another way is you can actually do a referral through Epic and do ambulatory referral to geriatrics. The key here is that you have to put reason for referral is falls, so that we know that this is why we're seeing this patient and they'll be going to the appropriate clinic. What you need to include in your referral is tell us which patient it is, who we should be contacting, and the phone number. And please include 2 phone numbers, including a cell phone. The setting that you're referring from, is it inpatient, is it outpatient? And then a little bit of details about the falls and what happened with that fall and the injury, and anything that you think might be useful. What does happen with these patients is once you refer them, our nurse phones them, make sure they're appropriate, and then we'll set up an appointment for them. So that's all I have, and I wanted to thank you for inviting me to speak with you all, and I'm happy to take questions if you have any.
Thank you so much, Dr. Rughwani, for being here. So yes, if anyone has any questions,